Hello, everyone. So we will be continuing with clinical cases, so respiratory section. We are doing chapter 27 and 28, clinical cases for FOP, and starting with chapter 27, asthma clinic. You're seeing patients in the asthma clinic. This list of investigation, blood sample for genetic test, bronchoscopy, ciliary motility study, CT scan of the thorax, diarrhea of peak flow meets measurements, esophageal peace study, spirometry, sputum sample, sweat test, sleep study. For each of the following, children select the most appropriate investigations. Question 1A, B, and C. Around is a 2-year-old boy who has a recurrent chest infection, which has not improved, will inhale salbutamol and inhale corticosteroids. His mother says he has hemorrhoids. His weight is on the 10th centile. His chest X-ray reported as being normal. 1B, Beth is a 60-year-old girl who is woken frequently at night by a cough. She also coughs when running about. Her cough is improved by inhaled salbutamol via a large volume spacer. Her weight is on the 50th centile. Her chest X-ray is reported as normal. 1C shows a 2-year-old boy presents with abrupt onset of cough. The cough started after he had been at the birthday party a week ago. Another child at the party has subsequently been diagnosed with chickenpox. His weight is on the 50th centile. There's wheeze heard at the right mid zone. Chest X-ray is reported as normal. Dan is a 4-year-old boy with Down syndrome. He has asthma, which is well controlled on inhaled salbutamol. His mother is concerned that he appears tired almost every day. He seems to sleep well but snores at night. Question 2, which is about the most important next management step, commence steroid inhaler, diary of peak flow measurements, otoscopy, a referral for ENT examination, sleep study. And we'll wait for 5 seconds, and then we'll move on. So the answer is 1A, answer is sweat test. 1B is diary of peak flow measurements, and 1C is a bronchoscopy, and then it was sleep study. So Chaplain implies a common issue periodics medicine journal. People are frequently labeled as having a common diagnosis, in this case, asthma, when in fact they may have a different underlying etiology for their symptoms. When approaching any clinical representation style question, visit them at the office. Presentation style question is important to identify any concerning or unusual elements of the history for the first boy, or in the fact that the cough is chesty and that he's failing to thrive, coupled with the history of hemorrhoids, should start alarm bells ringing that he may have cystic fibrosis. CF is a multi-system autosomal recessive disorder and the most common life-threatening genetic disorder in Caucasian population, inherited as an autosomal recessive condition. 125 Caucasians are carriers with delta F. 508 being the common mutation, 66 to 70% known cases of CF have delta F508. Caused by the presence of a mutation, both copies of the gene for cystic fibrosis transferrin conductor regulators CFTR. It can present early as component earliest in newborn babies or later as failure to thrive due to pancreatic involvement or recurrent chest infections. To answer the question, knowledge of diagnostic tests for CF is needed as the STEM asks for the best next step. This is important as some of the options are used for the management of CF but not a diagnostic tool. So test the gold standard diagnostic test for CF. It works by applying pilocarpine along with small electrical stimulation to a small layer of skin, increase sweat information, and rating the amount of fluoride in the sweat of the sweat fluoride is less than 40. It is negative test. At 40 to 60, then it is a borderline test. If fluoride concentration is greater or equal to 60, then this indicates for CF. Positive sweat test can also occur in children receiving topiramate, underweight infants, in disease, nephrogenic diabetes insipidus, and hypothyroidism site has active eczema. Though these conditions should be distinguished from CF by the presenting phenotype. There are more than 1,000 different alterations of CFG, and the standard genetic analysis will detect approximately 90% of these mutations with the rare mutation not tested for. If this genetic test is not homozygous for that SCF gene defect, it may be that the individual carries one of these rare mutations and does indeed have CF. For this reason, genetic testing should not be the first line test for CF in preterm infants and those less than 2 weeks of age. Genetic testing is often the first line investigation as they often do not produce a sufficient volume of sweat to analyze. Cystic fibrosis is an ultra-organ disease in the lungs and mucus clots the airway and traps bacteria, leading to recurrent infection, excessive lung damage, bronchiectasis, and eventually spidophilia. Staphylococcus, Xenophilus, Pseudomonas aeruginosa are the most prevalent infection in CF cardio. Respiratory complications are the most common cause of death. CT scans can be used to allow assessment of the evolution of CF disease, but is not diagnosis to bronchoscopy is also used in CF to obtain lower airway specimen for children who are not able to expectorate. It can be used, therefore, to guide antibiotic treatment. Pancreatic involvement can cause CF-related diabetes. Is seen in 30% of adults. Exocrine pancreatic insufficiency is commonly presented as fatty, bulky stool, cirrhosis due to malabsorption as failure to thrive. As in the case, enzyme replacement is the mainstay of treatment. Creon. Constipation occurs due to altered intestinal fluid composition, which can lead to hemorrhoids. Organ system complications in treatment alone. Lung mucus buildup, impaired ciliary clearance, inflammation, infection, prophylactic antibiotics, methods of expectation, physiotherapy, nebulizing, and IV antibiotics for exacerbation, long-term complication, rheumatoid pulmonary hypertension, and cardiac respiratory collapse. Pancreas, exocrine, pancreatic insufficiency, causes steatorrhea, malabsorption, ADEK, fat soluble vitamin deficiency, coagulation disorders, and treatment is supplement pancreatic enzyme, creon, dietitian involvement, gastrostomy is severely affected, and it is long-term complications related to pancreas is endocrine, islet cell damage, cystic fibrosis-related diabetes, vitamin D deficiency, the treatment insulin, vitamin D supplementation, and the CFI diabetes, reduced bone mineral density, EMT polyp formation, treatment surgery, blockage of nasal passages is a long-term complication. And GI, mucormycosis neonate, rectochloride, hemorrhoids, and respiratory reflux disease, distal obstruction syndrome, cirrhosis, stool softness, anti-reflux medication, and surgery. And long-term bleeding disorders, bowel obstruction lesions, reproductive congenital absence, vast deference, and poor motility, thickened cervical mucus, and IVF is the treatment. With Red's presentation, the presence of eczema response to beta-2 agonist means it's likely that she does indeed have asthma. Troublesome nighttime symptoms indicate the likely need for escalation of treatment with the addition of inhaled corticosteroids. Monitoring peak flow will allow you to have an objective measure of the response to inhaled corticosteroids. Please see chapter 10 to debate further information on the management of asthma. We have done chapter 10, we'll do chapter 28 after this. When Charles presents with abrupt onset of cough, you should monitor diagnosis of inhaled foreign body. Being at a body increases risk of finding objects to inhale, still develop chicken pox all the time. That would be unusual in any strain. Additionally, the incubation period for varicella is 7 to 21 days. Varicella pneumonia presenting after onset of rash, being told the wheeze is inclined to right medicine makes viral induced wheeze, classical diffuse wheeze unlikely, and a foreign body most likely due to classical right main bronchus preference. The fact that chest is normal is put there to cause doubt, but it may be normal in up to 35 cases of foreign body inhalation changes are best seen on respiratory films, which are difficult in uncooperative children. Bronchoscopy is the investigation of choice to both identify and remove the foreign body and will require referring to ENT or tertiary respiratory specialist. Urgent bronchoscopy is essential as the area of lung being under ventilator remains well perfused, causing a BQ mismatch and thus bronchiectasis. The CT scan of thorax would aid in the diagnosis of foreign body but would not help in the management removal and so is incorrect. Dan's presentation is classical of obstructive sleep apnea. This is caused by significant obstruction of the upper airways during sleep, resulting in apnea, complete cessation of airflow, hypopnea, significant reduced airflow presence, hyperventilation, hypercapnia, hypoxemia, and obstructive sleep apnea is one of the common presentation of children with large adenoid and tonsils. Children with Down syndrome are at risk 30 to 60% due to Factors including being considered hyperplasia, midfacial and mandibular hyperplasia, hypotonia, small upper airway, and macroglossia. The investigational choice would be sleep study, which would guide treatment. Respiratory medicine, ENT, know the presentation, cystic fibrosis, principal treatment, and cause of chronic cough and appropriate investigations. Now, the last one from respiratory section, I think, is this, the 28th one. A wheezy day. Urine call for pediatric questions. Eric, a 9-year-old boy with a long-standing history of asthma, attends for an acute exacerbation of breathlessness with wheeze on admission for oxygen status 91. His heart rate was 120. He had a visceral breather, was using his sissy muscles. The emergency department SC1 doctor gave him nebulized salbutamol, ethylene, giving the oxygen and oral prednisolone. After this, the oxygen saturation 92 and 50% oxygen, but he's drowsy. Poor respiratory. If he calls, they will ask him for advice and you arrange to review him with your consultant. Which one treatment should be advised to when doctor initiate whilst you are on your way? IV bolus of hydrocortisone, IV bolus of magnesium, IV bolus of salbutamol, IV magnesium infusion, IV modified infusion. After reviewing the emergency department, doctor asks you to review 3 more children. There's a list of medication available in the emergency department. Inhaled protopium, vice spacer, inhaled salbutamol, vice spacer, IV aminophylline, and IV hydro cortisone, IV sulfate, IV salbutamol, nebulized evergreen, given by oxygen, nebulized salbutamol, given by oxygen, and prednisolone and oxygen, which is the most appropriate initial medication for each of the following children presenting to the emergency department. A 3-year-old girl with a history of asthma attends with an acute exacerbation of oxygen saturation of 90% in air. She has widespread use of auscultation. 2B, a 5-year-old boy presents with a cough and his oxygen saturation 96 in air. He has widespread use of auscultation. 6-year-old boy with acute respiratory distress has oxygen saturation 90. He has widespread use of crackles or auscultation. So the answers. So we'll wait for 5 seconds and then we continue with it. So answers of question number 1 and the treatment would be on your way, IV bolus of salbutamol, and for the first child, you will give nebulized, nebulized salbutamol given by oxygen. B, inhaled salbutamol by spacer, and J is oxygen. And the first case, this child is initially presenting a severe exacerbation of asthma and which, despite initial appropriate management, has demonstrated deterioration with him becoming drowsy and his very rapid deteriorating, having life-threatening asthma. In this situation, urgent review by a senior clinician is required and consideration of intensive care admission is asthma, severe and life-threatening asthma. Breathlessness, preventing talking in full sentence or feeling saturation less than 92, PF 33 to 50, best of predicted. Tachycardia is heart rate is more than 125, more for more than 5 years, or more than 140 for 2 to 5 years. And tachypnea more than 3 breaths per minute, more than 30 breaths per minute for more than 5 years, and in 2 to 5 years, more than 40. And the life-threatening oxygenation less than 92 and peak EF less than 33, best of predicted silent chest, cyanosis, poor respiratory hypertension, exhaustion, and confusion. You're also having confusion. So it is important that you follow the latest guidelines on measurement of acute and severe lines that in the SIGN guidelines, Scottish Intercollegiate guidelines network states that if there is failure to respond to inhaled therapy, then a bolus of salbutamol should be administered. It is also important that you might respond to any treatment carefully with the following parameters. Follows increasing tachycardia generally denotes worsening asthma, fall in heart rate, and life-threatening asthma is a pre-terminal event. Respiratory rate and degree of breathlessness. Use of excessive muscle expression best noted in the patient of neck muscles. Amount of wheezing, which might become biphasic or less apparent with increasing air restriction, radio agitation, conscious level. All this give calm reassurance. It is important to note, however, that clinical signs correlate really with the severity of air restriction, and some children with acute severe do not appear distressed. Oxygen therapy saturation should be maintained at 94% above. Bronchodilators, mild moderate asthma, metered dose inhaler, special permission bronchodilator therapy, added protopium bromide to nebulize beta 2 agonist therapy. If symptoms do not resolve the initial treatment, steroids give early to maximum effect. 3-day course, not tapered unless more than 14 days have been administered. Prednisolone less than 2 years will be 10 mg, 2 to 5 years will be 20, and more than 5 years 30 to 40 mg. Prednisolone. Consider IV steroids if repeatedly vomiting or steroids. Secondary treatment, IV salbutamol bolus in severe asthma if not responding to inhaled treatment. These were inhaled with steroids and IV. And minor failure in unresponsive severe life-threatening asthma, IV methicillin does not yet have an established evidence-based, but is a safe treatment. The next two children, to A and to B, also have acute wheeze but are presented with milder symptoms. The first child has low oxygen sat, so requires oxygen as well as bronchodilator therapy. Second child has normal oxygen saturation but device therapy. There is now good evidence that inhaled beta agonists from a metered dose inhaler is effective and are the preferred administration to mild or moderate asthma accessible. 6-month old is presented with commonest cause of these bronchiolitis. Bronchiolitis is a lower respiratory tract infection most commonly caused by the RSV and generally affects infants under the age of 1 year. Typically presents with cough, wheeze, restlessness occurring over several days, widespread crackles or wheeze are typical findings on auscultation. Restlessness may persist for several days, and commonly the airways remain hyperreactive for several weeks, leading to recurrent cough and wheeze. There is no effective treatment for bronchiolitis, and management being mainly supportive. Salbutamol therapy is ineffective as children of this age do not have effective beta 2 adrenal receptors in their lungs. In patients with bronchiolitis, oxygen saturation should be maintained at 92% and above with the use of oxygen. Children with severe respiratory distress could require additional supportive therapy, which may include nasopharyngeal fluid respiratory failures involving CPAP or ventilation in the need for respiratory support. Certain high-risk groups of children receive massive immunization against bronchiolitis as it has been demonstrated to reduce the severity of respiratory symptoms and incidence of intensive care admission in those groups. And research respiratory medicine with ANT and know how to assess and manage acute asthma disease and plan long-term management, understand the cause of chronic cough and appropriate investigations. So this is all. I think we will do. Somebody was saying that we should do the theory and science first too. How many questions are there? Okay, we'll discuss this. Thank you very much.